Hello and welcome to the Clinical Liver Disease video series. CLD is an official digital learning publication of the ASLD. I'm Thomas Cotter, Assistant Professor of Internal Medicine at University of Texas Southwestern in Dallas and Social Media Associate Editor for the CLD. I'm here with Professor Holden Su from Taiwan and the author of Finite Therapy of Chronic Hepatitis B Infection, The Cons, publishing in an upcoming issue of CLD. Professor Su, thank you very much for joining us, and thank you
Thank you,
and
Dr. Carter.
your efforts in writing this excellent article. So I'm going to ask you a few questions, if that's okay with you.
Yep.
Question one.
Thank you, Dr.
Why is treatment withdrawal not an ideal way to provoke immune reactions against hepatitis B?
Okay. Thank you, Doctor, for having me. My answer for the question is that because the provoked immune reaction can go beyond control, and there are risks of severe flares following a treatment withdrawals. According to the literature, which is detailed in the article, severe flare-up with hepatic decompensation could occur in approximately 1% of the patients who stop the treatment by the current stopping rules. So there's a risk.
Okay. And a follow-up question to that, can't we predict the risk of hepatitis flares following treatment withdrawal, perhaps?
Currently, we cannot reliably predict a safe treatment withdrawal without the concern of severe flares. Indeed, there are some biomarkers like quantitative surface antigens or core-related antigens, and some demographic features like age and fibrosis status. They might help us to stratify the risk, but an accurate prediction is not always guaranteed, and the consequence can be serious.
And would you consider stopping treatment in kind of any scenarios or under certain conditions?
Yes, zero clearance of hepatitis B surface antigens is probably an acceptable treatment endpoint. Other than that, if patients wish to stop the treatment without clearing surface antigen first, then they have to do it in a carefully designed settings with ethical safeguards, informed consent, and close monitoring. So this practice can be restricted to a minority who meet stringent selection criteria.
Okay. And so I guess if you're like going to look at like a standard of care for Hep B infection, like is there a way that finite therapy could be accepted as the standard of care?
The practice could be accepted as a standard of care only if the target group can be clearly identified. I mean, the patient group. And definitive long-term outcome data from randomized trials confirm there are tangible benefits of finite strategy versus indefinite therapy.
Okay. And then I guess just want to like close by maybe asking about some of the potential harms of finite therapy. So what kind of negative impacts could the fervor about finite therapy impose on like viral hepatitis elimination, for example?
Right. There are some enthusiasms recently about finite therapy. And I would say that overemphasis on finite therapy could undermine public trust in antibiotic treatments, discourage disease monitoring, and may distract focus from scaling up the treatment approach to meet the elimination goals of viral hepatitis. So there could be collateral harms or damages to our efforts to eliminate viral hepatitis.
Okay. Professor Su, that was all very interesting. And thank you again for joining us for another installment in the Clinical Liver Disease video series.
Thank you again for having me, Dr. Carter. It's my pleasure.
And thank you to the audience for joining us. On behalf of us all from the CLD team, I hope you found this interview with the author useful. For more information about this article and for many more great educational articles, please visit us at www.cldlearning.com. Thanks again for watching.